I want to start at the most basic level, and anyone is willing on the panel to answer this question. It was stated in the earliest presentation that women above 40, can achieve pregnancy without assistance. In fact, over a course of a year, that rate sounds actually relatively equivalent to some IVF success rates. So my question is, how do we distinguish which woman of advanced maternal age needs treatment, and how do we distinguish which women can actually be effectively assessed to have expected management as their treatment?
Anyone from the panel, and then I can comment if you ask me to comment, but the panel first.
Yes, Professor Hassan. Yes, can I speak?
You want me to reply?
Yes,
Salah,
please.
You want me to reply?
No, I want to reply, yes.
Please.
Okay. Thank you, Professor Kert. I think before going on to this webinar, we discussed that fastly. I think that the AMH and the antral follicle count in this condition in particular plays a very important role. As Professor Iman stated, that the last recommendation of the ASRM regarding this age group specifically is somewhat redundant. It pushed that the woman should be treated fastly and immediately without making a limitation for this period of time. But I think for me personally, the AMH and the antral follicle count is very crucial. So if they are reasonably good, we can wait not more than 6 months. But if there is impairment in the ovarian reserve, I think we should go directly for IVF.
Another comment from the panel to Professor Barnard's question. Tricky question. Iman, do you want to reply?
May I make a comment on this?
Yes, please. Yes. Dr. Marina, please.
Good evening from Thessaloniki. I would like to congratulate all the speakers for their complete and interesting presentations. I'm very pleased I'm here today with you. About the previous question, it's important to know the other factors of fertility or infertility. So we should check chances of a natural conception. And also, it's important to know if the particular declining of the fertility is advanced or retarded, because it's not always the same. Yes, the age is the dominant factor, but the declining fertility might be advanced or retarded, and there are some markers or predictors we should take into account, and also to know the other factors of fertility or infertility of the particular couple. Thank you.
Very good.
Professor Hassan, would you like to respond?
Yes, I would like, if no one from the panel would like to further. Of course, I know your trick. Okay, so what Kurt actually said is that they have high pregnancy rate, spontaneous pregnancy rate. What should we do? And the idea is, as Dr. Marina said, you should exclude male factor and tubal factor because these will need treatment for ahead. But afterwards, you cannot do 6 months and say IVF, because the current copy of IVF is a bad copy in those advanced maternal age persons, ladies. And we have shown data that after 6 months, the spontaneous pregnancy rate is around 20 or 15, but it doubles after a year. So why should you do anything before a year? Because of MH is not predicted in this age, because the curve plateaus in this time. Antral follicle count, it's not either predicted, and you cannot even claim that with low MH that she's approaching menopause. So I think that we should wait for a year. If there is no tubal factor, as Dr. Maria said, no sperm factor, and no other factors to be blamed for infertility. So what's your response to this, Kurt? Professor Barnum?
Yeah, so my question
Wait for a year.
My question was tricky on purpose. I think we have to understand a very important comment that the data presented about unassisted pregnancy rate at that age is of a population of sorts. And I understand the number is hard to get. But many of those women who can conceive without any assistance don't come to our office. So when somebody does come to our office saying they're seeking fertility, they have to have the same workup as anybody else. And you have to take account into, have they tried before? How long have they been trying? And I would advocate that you're looking at a select group of women because they're in your office looking for fertility. And if they have had 6 months of infertility, I would go ahead and treat. So I wanted to make the difference between them. Now, there's a very important caveat there. If you do your workup and you have a very low AMH and you have a very low antral follicle count, there's another question I'd ask the panel is, how much is IVF actually helping? Maybe the treatment is in other ways. It's ovulation induction. It's making sure the timing is correct. It's making sure you're healthy. Because if you are only going to get a very few number of eggs from IVF, is that actually helping a woman at that age? What does the panel think of that approach?
Very good, very good. Iman, would you like to respond? Voice.
We are now talking over 40?
Yes.
Yeah.
Typically? Okay, so we have to differentiate between 41, 42, this is one category, 43 to 45. Because I think there is distinction here. Even in literature, pregnancy is different between 41, 42 and 43 to 45. There is more and more decline. So women coming in this promising category should be dealt with. For me, I will not wait long. I will go for what I do actually in practice. I will go for ART to maximize their chances per month to get the highest number of oocytes monthly. Of course, if they have good reserve, it would be very promising. And if they have low reserve, I will be so keen on very careful counseling, on having different options, whether starting with the ordinary stimulation, if not to go for the soft protocol or dual stem, so that to get as many oocytes as possible.
Ashraf, would you like to comment?
Yes, thank you, Dr. Hassan and Kurtz. I think for myself, if the AMH is okay, I can wait for 6 months for that patient carefully, if she is convinced, because in our country, usually they're coming after 3 months and they need to start treatment. But I want to highlight that the Poseidon Group 4 is named for or categorized for patients over 35. And so when we are speaking about over 40, it is not a so young age. And so we should consider them as a very serious group. And the other point, the number of oocytes that leads to embryos with aneuploidy per year in that age, we should consider that if we do accumulation or if we go to IVF, we will maximize the number of oocytes that we can gain. And so we can help them to get pregnant so much better than waiting for the 10 oocytes or 12 oocytes for 1 year they will gain from normal regular cycle.
Dr. Marina, would you like to comment?
I agree with all previous comments, but I would like to add that we should not forget that assisted reproduction has also a diagnostic role. When we retrieve the egg and before the fertilization, and we can see the embryonic development, we have a lot of important information about the couple, their gametes, and all the chances they have to conceive. I agree that I would go straight forward for IVF.
Hisham?
Yes, I will actually differentiate very well between 40, 41, 42, and 43, because the older the patient, I think the more urgent treatment is needed. And I think that patients who are capable of, and financially and morally, they are capable of doing embryo accumulation, I think this will have better chance than waiting for spontaneous pregnancy, because with embryo accumulation and stem, you can even have double the number of oocytes that you can get in one cycle. You can get double the number by stem. Adding PGTA is critical because it needs to use it cautiously in centers with high proficiency. Otherwise, damaging the embryos will negate all the benefits they can get from PGTA.
So in response to Professor Barnard's question, you said that if a patient more than 43 entered your office with low ovarian reserve, you will say either embryo accumulation or you go, or you will still do a one cycle?
No. You have to give the patient the choices. If she can afford embryo accumulation and PGTA to reach the number of oocytes that you expect, by which you will get one haploid blast, then you can go. If she cannot,
part of his question was, why don't you just give her the alternative? Because her chances with your procedure is lower than her natural chances. Why don't give her clonfil citrate, or give her whatever without ART? Because she doesn't have real chance with ART. This was his question.
Patients in which you expect to get one oocyte by stimulation will not get benefit from IVF. But if the patients, if you can get
fair.
two or three oocytes, it's different from one. And then you get 2 or 3 oocytes with stem every 2 weeks, and then you can get 6 oocytes per month. This is different from 1 oocyte in the spontaneous cycle.
So we're talking now about whether they will afford the money or not. Salah, Professor Salah.
Yes.
In response to Professor Kurt's question,
yes,
please.
I guess that Professor Kurt will ask a different question. I guess that some other expert may ask him at the age of 40 whether you will proceed directly to IVF with PGT or without PGT, not how much you will wait till spontaneous pregnancy. I totally agree with Professor Hisham that the chances of spontaneous pregnancy on ovulation induction with unifollicular or even the response at that age is not so good to ovulation induction. So I totally agree with Professor Hisham. I'll proceed and with Professor Iman at the age of 40, not 41 or not 42, the chances are too small.
So you wouldn't do IVF in patients in an advanced maternal age with low ovarian reserve. You wouldn't do IVF. You would choose to try first.
No. With good ovarian reserve at the age of 40.
With poor ovarian reserve. The question was poor ovarian reserve.
No. I'll proceed directly to IVF.
Hisham, did you say that?
I said yes. I said with very low ovarian reserve, you will get nothing more if the patient does not have any other factor of infertility. If the male factor,
you will do IVF?
I do IVF. One who will produce only 1 oocyte?
Yes.
It's a difficult question, actually, because you have to try first. You have to try first for a limited period of time, and then if it fails, then you can go to IVF. But with extensive counseling.
Of course, we have a lot of lab director experts with us, and I think this is very interesting for all of us. Dr. Klaus, can you comment about Professor Barnard's question whether in a patient with advanced maternal age and a low ovarian reserve, you would advise, according to your KPIs in the lab, you would advise the clinician to go for IVF or for any other thing to try first? What do you think?
First of all, thanks very much for including me in this amazing webinar and to be included with such a group of wonderful scholars.
We are honored to have you with us. Fauzi recommended you highly, and we all know you.
Thank you so much. But it's good to be here. Yes, I can comment on that. So in our IVF clinic, we clearly discern that, between the ages of 35 and 40 is a very distinct group than after 40. And that's simply because the aspect of aneuploid and other complex abnormalities in the embryos really begin to increase logarithmically. So really, I don't think there's a clear-cut answer to that. I think for Kurt to answer that, I would have to say it depends. It would depend upon the AMH. It would depend upon the follicular or antral follicle count. And it would also depend a lot on the day 3 FSH. And the reason why I say that is because once you have this information along with the semen characteristics, you have an idea of what's going on. So for example, a woman who's 36 years old and has, declining AMH values, we might treat her as urgently as a 40-year-old woman who's got a declining AMH. So we would immediately do one of two things. If AMH value and prognosis of getting a lot of eggs is high, we would proceed with an IVF schedule and do treatment and collect all of the embryos. If we can, we try to do conventional insemination for a lot of the reasons that Dr. Fauci mentioned. We feel that these eggs are a little bit more subject to the invasive aspects of ICSI. So we would try to minimize ICSI, try to maximize the use of IVF because we get about a 7 or 8% increase in blastocyst development. And then we would grow those embryos out to day 5, 6, 7 and biopsy whatever we can. If we feel that the patient is a low to mid prognosis, we do something called zygote accumulation, where we'll have the patient go through various cycles and we will freeze zygotes. The reason why we freeze zygotes are that from a cryobiology perspective, zygotes are really at an optimal stage. They're highly permeable to cryoprotectants. They freeze really, really well. They have virtually 100% survival rate. And you don't have the same impact as you do with the variability of freezing blastocysts. So we have some algorithms that we've built up that kind of determine how many cycles a patient should undergo before you batch zygotes. And we use zygote batching because overall it saves the patient somewhere between 23 to 25% of their cycle. So all those zygotes are then thawed out at the last treatment and grown out and then undergo embryo biopsy. So I think to kind of summarize what I'm saying is if the patient has good antral follicle count, we're of the belief of not really waiting too long, but rather take advantage of the physiology while we can have it and try to proceed directly to the scenario of IVF with embryo biopsy, minimizing ICSI in cases with lower antral follicle counts, possibility of having lower number of blastocysts. We apply some algorithms that we've developed internally that kind of let us know more or less how many cycles a patient should undergo to accumulate zygotes. And you can build these algorithms in your own clinic. You can look at, for example, what your ploidy status is within different age groups and then work backwards to determine how many embryos did it take for you to get to that point.
Yes.
I did want to make a comment. I did want to make a comment, though, about the dual stim, just from the laboratory perspective. I know we love the idea of dual stim, but for me personally, as an embryologist, I have not felt like we did as well with it. I often notice that these oocytes, cumulus complexes, tend to have a very luteinized appearance. When we do ICSI on these eggs, the proportion of them that have fragile membranes or lyse unexpectedly or worse, don't cleave, seems to occur more often. But for us, more importantly, when the proportion of ploidy embryos is much lower, to the point where we abandon doing the dual stims, but simply allow that patient to have that washout month and then simply start the stim again. Just from a laboratory perspective, my thoughts on the dual stim.
Very comprehensive. Thank you very much, Dr. Alexia. I think
Yes.
what Dr. Klaus said and what Kurt said and what Dr. Marina said about the diagnostic advantage of ICSI in this age group I think that you want to comment.
Actually, yes, I really appreciate what Dr. Professor Klaus just mentioned, and the thorough approach of the attitude and of going through an IVF procedure as soon as possible to take advantage of the high AMA and gather as many oocytes as possible. And this is my opinion as well, that we go to fight to the war when we have the tools with us, not take time and lose the power of having enough oocytes or quality of the cytoplasm, because one of the factors that deteriorates over age, apart from the quantity of the oocytes, are the cytoplasmic efficiency. We get to have lower mitochondria, lower micromolecules, which are quite crucial for supporting embryonic development. Where he lost me a bit is the zygote pooling, which is amazing. It's another attempt, and it's good to challenge. But with zygote, you don't know the quality of the embryo. So we gather something, and I would be happy if you would like to comment a little bit on that, because we lose the information of the quality of the embryo. And as Marina just said, it's a diagnostic procedure. It's important for the patient to have a correct feedback, whether the embryos are of good quality or not. Are they able to reach the blastocyst state? Imagine if they undergo 3 IVF attempts and end up with no blastocysts. It's a disaster. Nobody wants to go to have an overview meeting with this couple. They may be exhausted, tired, and well, disappointed. On the other hand, I like the comment of Duo Steeman. Thank you for setting it with us, because in our case, we don't have that much of experience. We had just started our Duo stimulation. So it's very important to know the biophysics of these oocytes. The idea is good, but does it really add on the overall prognosis of the patient? That's a very nice comment.
Thank you.
Thank you very much for a very, very comprehensive reply. I just want to say something funny. Dr. Klaus and myself, from the way our age is, we loved zygotes. You didn't know zygotes.
I knew.
You came with blastocysts. You are in the era of blastocysts. We loved zygotes. We used to freeze zygotes, and we loved them.
Yes, but you freeze blindly.
It's a joke. Alexia, it's a joke.
Well, you're kind of right what you're saying, Alexia, because one thing we've learned, though, is that when you're freezing zygotes, and I apologize for not mentioning this important factor, we often will tell the patients after we freeze the zygotes how well they freeze. Often by how well the oocytes freeze, you can tell with anybody who's on the call who's vitrified oocytes or embryos. When you're in the process of vitrification, you learn a lot about how well the membranes are reacting. And we all know there's really high correlations between membrane characteristics during the dehydration process and how well they survive. So you're absolutely right. If the patient, say you're freezing 4 or 5 zygotes the first time and they freeze very suboptimal, we may actually tell the patients, you know what, this may not be the best plan for you, because our initial impressions are that although you had a good fertilization rates and you've got 2 PNs, the structure, how they behaved while during the freezing process suggests that your egg quality may not be very well. But the good thing is we've got tools now available for that, which, be glad to talk about as well.
Thank you very much. Dr. Fauzi, I think you need to comment, then Iman will comment, then Sharif Gafar will comment, then we'll go back to Professor Kirkburn.
Yeah, my only comment is related to the DioStem. DioStem, in our perspective, or what we see, is nothing rather than wasting time and wasting egg.
Very good.
Ooh.
This will take us to another question, but this is very important point in this webinar. Okay, Fauzi, do you want to say anything more?
No, thank you.
Sharif, Professor Sharif Gafar. Then Iman will ask Kurt Barnard, and Kurt Barnard will take the hand again. Sharif, open the voice. Open the microphone.
Yes. Thank you, Professor Hassan, for the nice invitation and for the wonderful webinar. Yes, I think we should always think about the number of oocytes. Talking about 1 or 2 oocytes is completely different than a case that can produce 4 or 5 or 6 oocytes. We can divide this group of patients into subgrouping, either with good AMH or very low AMH. It's different to talk about a patient which is 37 or 38 years old with AMH 0.7, or we are talking about the same patient with AMH 0.2 or 0.3. I think that good prognosis patient can benefit from oocyte accumulation and PGTA. However, bad prognosis patients, almost all the options are equal, as we are talking maybe about just natural conception or even IUI. So in good prognosis patients, we could do our best to help these patients, while in poor prognosis patients, maybe we could think about more cost-effective options, as most of the options are of very low pregnancy rate and also very low live birth rate.
Very good. Professor Iman, you can ask Professor Barnard what you want.
Yeah, actually, Dr. Barnard, as I was discussing with you before webinar, in ASRM Committee for Women, it stated that in women older than 40 years, a more immediate evaluation and the treatment may be warranted. So I would like to know what's meant exactly, how long we should wait according to the guideline, and what is the steps to go through.
Sure. Let me see if I can summarize the discussion and answer your question at the same time. So what I heard from this very informative panel was that when you're dealing with a woman with advanced maternal age, there are a number of factors that come into play. First, you have to treat them the same you treat any other woman and make sure there's no other causes of infertility. Secondly, you have to take into account the history of how long they've been trying. And if they have never yet tried, giving them a period of expectant management is reasonable. But the main message I heard was, remember what IVF is doing. IVF is helping a patient because you are able to accumulate multiple oocytes. In a younger woman, 35 to 40, low AMH means fewer eggs, but the eggs still might be high quality in terms of aneuploidy. In an older woman, you have both a low number of eggs and a very high chance of aneuploidy. So if you don't think you're going to get a lot of embryos, IVF may not be helping that group. Now, so what ASRM meant by immediate treatment is that if somebody really does have infertility after 6 months, you should immediately go to evaluation to find out what else might be wrong. And you should immediately go to treatment. It doesn't tell you what the treatment is. It has to do with all of these things I just talked about. However, I'm going to ask a question back to the panel. If you have a woman that goes through IVF because there is some diagnostic ability to it, and they only make a few embryos, is it worth doing PGTA when you only have 1 or 2 embryos?
For me, no. Per one cycle, without her willing to do embryo accumulation, no, I will not recommend. Definitely, I will not recommend per cycle. Actually, and the other factor is, if she already has 1 or 2, she might even have a risk of extended culture, and she can lose everything. So we have to do very careful counseling to do for cleavage or to take the risk for extended culture. But doing PGTA, I will not recommend.
That's the gist of my question, because it's interesting, right? PGTA has advantages of screening for aneuploidy, but if you only have a few embryos, is it worth screening for aneuploidy? I'm excluding, in this case, embryo accumulation. That's a different logic. So I'm asking the panel, in this case, you've taken your woman to IVF, she only has 2 embryos. Is it worth doing PGTA?
I personally kind of think it depends, Kurt. In other words, if the patient has come to the clinic and has had a history, of repeated miscarriages, and this creates a huge amount of patient unrest. I know in our center, we have patients that says, I want to go, if it's a blast or bust situation because I don't want to go through what I've gone through in the past, versus another patient says, the embryo transfer aspect, I need to experience, going through an embryo transfer. That's a really important part because that's part of the journey. So I hate to be ambiguous, but it kind of depends a little bit about the journey that brought the patient to the clinic to begin with.
Okay.
Very good. Professor Mahdi, do you want to comment on the current discussion?
Yes. If the case has one or two embryos, I think it's better to transfer it fresh, and you can repeat the cycle next cycle and give her the chance of repeated embryo transfer. I think BGTA is only a way to enhance or make it hurry to or rapid to transfer the single best embryo. So if I transfer 6 embryos successive or 3 embryos successive, I may have one of them which is euploid embryo by chance. So I save money of BGTA and transfer single embryo by every cycle. I may have a pregnancy.
Nihal, would you offer in your lab anything for Dr. Barner's patient?
Actually, dear professor, from all your talks, you consider only the end of the story, the transfer of the euploid blastocyst. And we are now should to open a new door for new strategies and new perspectives regarding to the quality of the oocyte from the beginning. If we take other perspectives or other strategies to improve the quality of oocytes, which in case of advanced maternal age, compromised with many factors regarding to mitochondrial dysfunction, oxidative stress. So if we working to improve these issues, we may improve the developmental potential of this oocyte. Then will get a more chance for euploid embryo and become with not in need for these interventions. One of these perspectives, the role of mitophagy of the mitochondrial dysfunction. If we consider how to improve this pathway to improve the mitochondrial function in the aged oocyte, we may have a better outcome of the quality of oocyte, then its potential to develop and form euploid blastocyst will be better at the end of the story.
Dr. Nihal's doctorate degree was about autophagy, and mitochondria is and mitophagy is the autophagy of the mitochondria, right?
Yes, it is the scavenger.
So are you suggesting spermidine, for example, or coenzyme Q10 or what?
Dear Professor, spermidine pathway, it is a way to improve the pathway of the autophagy or mitophagy by deacetylation pathways, and improve the genetic coding for all genes, encoding and enhance the pathway of the autophagy.
So it improves mitophagy.
Yes. Dr. Hassan, we also published an article in the Journal of Assisted Reproduction and Genetics regarding to autophagy and its role in blastocyst development, and it proves that blastocyst with high function of autophagy have a great euploid embryos and a good morphology blastocyst.
Yes, thank you. Is spermidine present in food? Something to be eaten?
Yes, it is widely present in legumes and vegetables. Also, it is present as a supplementation, a capsule supplementation in the market.
Thank you very much. Professor Ashraf, Dr. Ashraf Abu Ali. Ashraf.
I think that yes, yes,
Ashraf,
yes, I'm hearing you.
can you tell us your opinion about vitamin D because it acts on AMH, or about Q10? What do you
Yes,
think in those women? The voice is low. The voice is low.
The voice is okay. I have a comment as regards. Can you hear me or not?
No.
Can you hear me?
Yes, better.
Hello?
Better. Now better. Better. Yeah.
Can you hear me now? Okay. I just have a comment as regards Professor Kurtz's question. I think in our country, we should consider the dropout ratio, because in that age, if we do BGTA, such an expensive point for the patient, the dropout is very high. And so in these patients, I prefer embryos accumulation till I have an enough number for these partners, for not to make a break in this family, and to try to have at least enough number of euploid embryo, even if I didn't go for BGTA. And I think that the literature supports that fewer than 4 oocytes, we should not go for BGTA with good heart, because it will not improve live birth rate, and it will not improve except miscarriage rate. It will lower miscarriage, but we should have 30 cases for only one case to improve miscarriage. So I think this is the best way we can go for. As regards adjuvants, Professor Hassan asking me about, I started to use a long time the coenzyme Q10 and even the growth hormone. And I think that even after the last issue guidelines raised up, I think that a lot of meta-analysis now is present to augment the number of oocytes, the fertilization rate, and even in a lot of publications, the clinical pregnancy rate is good with a lot of those adjuvants, especially coenzyme Q10 and growth hormone. Even if the evidence is not yet enough, but as a fact, it is still growing. And I think this is better than the DO-STEM for me to do, and it is less expensive than than the embryo vitrification. And I think that cryopreservation is now raising, and so we are in a need for more embryos to vitrify to help patients, because we have a lot of old age patients got pregnant with vitrified sowed cycles. We had good results with that, 43 and 40 more. That's my opinion for that.
Thank you. Professor Barnett, disparate situations require disparate measures as long as they are not expensive nor invasive. Do you agree on using vitamin D? There is evidence, there is some evidence. So do you agree on trying vitamin D in those poor patients? Just it may help, and it has a theoretical background?
Yes, I do. I think supplements that are not expensive and that are harmless, I certainly have an avenue to use, and I would consider vitamin D and maybe CoQ10 in that category. However, I'm not convinced that things like growth hormone, which is expensive,
Yes,
has been demonstrated to have any efficacy. The literature on that is very mixed, and there are actually legitimate questions on trials that have shown benefit if the data was actually true to the study. So I would be careful on expense and invasiveness, but non-invasive treatments, of course.
very good, very good. Professor Madhat Amer, do you have something to add from the point of andrology and being a director of one of the biggest IVF lab in our area? Do you have something to add to Dr. Kurt Barner's patient, the old patient with low ovarian reserve, either for the male, either in the lab, or whatever you want?
Yes. Do you hear me?
Yes.
Yes. I think older women are married to old men. And as we have seen, old men have a lot of problems. So even if the semen apparently is borderline normal, we have to see if he has a high DNA fragmentation or not. We have to go deeply in exploring the male condition. And maybe if we find that the male has a real problem, we will not delay the intervention of IVF. So thorough examination of this patient
because they have a problem due to age, simply due to age.
Very good. Very good. Kurt, would you like to proceed more?
Sure. So let me give you an answer to my own question first to summarize for the audience. I think that PGTA has the advantage of screening a large number of embryos to find the one that might be normal, and therefore perhaps more efficiently transfer the correct embryo. PGTA does not improve the quality of embryos. So if you, in fact, it may actually lower the quality of embryos. So if you have a low number, PGTA is not offering a patient an increase in success. So I agree PGTA is a good value if you have embryo accumulation, if you have a lot of embryos to choose from, but I don't believe PGTA is adding value when you have a low number of embryos. So that's just the answer to what I was describing. So I would ask another group, since it was a lovely comment, would you change any of your practices with a woman with advanced maternal age if you have a partner who's advanced paternal age? Do any of our strategies change?
Very good. Start with Professor Madhat.
Yes, of course. I think that when you are seeing a old woman, the first thing to see is the semen analysis that has been done in a good, appropriate lab, and that an andrologist has consulted this man. Because if you are willing to go through wait and see, you have to be sure that the male has no real problem. But actually, most of these men, as we have seen, have starting their decline in semen analysis, because a woman at the age of 40 will probably be married to a man of 45 or 50. So unless she's married to a man that has 25 years, she has no problem. But this is not the usual case. So it's very important to assess the male. And then when the male is well assessed and the andrologist has said, what does he think about the male? Here, with the gynecologist together, they can make a good plan for the couple, yes.
Let me be more specific in my question. Does that change anybody's plan for ART, or how you handle sperm in the laboratory, or the choice of ICSI, or the poor choice of PGTA? So please.
Yes, for me, if the male has a severe male factor, or if he is azoospermic, no time to lose. We have to start very early by ICSI. And I don't think that PGTA will add something if she has a very low number of oocytes, as you said before.
Alexia would look like she wanted to say something.
Yes,
Please.
yes, because this is the daily issue for me, and I would like to add first,
yes, please.
The quality of sperm of a man of advanced maternal age plays a major role when we have an advanced maternal age factor as well. And we have the benefit of having the option of taking and retaking the sperm and making sure that the quality of the sperm is optimized before it meets the egg factor. So we can screen the man with DNA fragmentation, ask him to follow a preconceptional optimization, follow a routine of frequent ejaculations, supplementation, lose weight, improve, quit smoking, follow all these, which we know and more we regularly advise our patients to follow. So once the sperm reaches the maximum capacity for improvement, obviously we cannot take that much of a time, but at least 2 or 3 months will make us able to improve the sperm. And once it is in our hands in the lab, yes, we can avoid centrifugation, for example, and follow a less invasive technique for selection of the spermatozoa, such as microfluidics, because this way we maintain a better structure of the DNA. And once we reach the level of ICSI, or if ICSI is to be used, because I do agree with Dr. Fauzi that conventional IVF may work better for these patients of advanced maternal age. But if we need to do ICSI, then IMSI should give us a better, a further improvement of the paternal factor.
Fauzi?
Yeah.
Fauzi?
For this category of patient, perhaps using the advanced sperm selection technique like microfluidics may add value with regard to the sperm function by itself. But with regard to the DNA fragmentation to enhance or not, or to look at improvement or not, at the Cairo Consensus Group of Andrology that published 2019, we pointed out the methodology used so far to diagnose the DNA fragmentation, as well as the treatment offered, as well as the effect of the FI on the outcome of male of ART outcome, need further studies to be established. So if I am going to advance sperm selection for this type of patient, this to enhance the overall sperm. But in my view, this shouldn't be should be at no cost to the patient, because this will not, there is no solid evidence to say that this process will affect significantly or clinically the result of them. So if I can offer them for free, it's okay. If the patient will be charged, I'll go for the standard after counting the patient, of course.
Dr. Marina, you have what do you think about patient with euploid blastocyst? How age affects them? Do you think that is still important when women with with normal blastocyst, euploid blastocyst, have transfer at age of 35, 37, 40? Does it make a difference, or that as long as they have a normal blast, age will disappear as a factor?
I think it's a really important question, this kind of question, because according to recent data, there is increasing maternal age seems to be associated with a decline in IVF success rates, independent of the employee of the embryos. And this has to do with factors different than chromosomal errors. One factor is endometrial aging. According to recent findings, it seems that aging significantly affects endometrial gene expression, especially in ages above 35. And we should not forget that when the age increases, there are some other uterine pathologies like adenomyosis or fibroids, which may interfere with the embryo implantation. In which way? It seems that these uterine pathologies modify the vascular architecture, impair the normal contractility of the uterus, and maybe change the production of angiogenetic factors. And that's why we have lower success rates when we put euploid embryos.
So this is double jeopardy for Dr. Kurt Barner's patient. Professor Salah Rashid, I thought that donor studies showed the less importance of the uterus, but now what Dr. Marina brought as data showed that it has some effect very early. She said 35 on some components of this. What do you think about the uterine factor in old age?
Yes, Prof, can you lead me to go somewhat back to, and add a comment to Professor Kurt, please, because it's a very important question to me. And I got the point that Professor Kurt asked about whether a woman with a male partner with advanced age and apparently normal semen analysis, whether this will change our plan of management
Yes.
or not.
Yes.
Whether this will change or not, this I want to hear the answer, because for me it's very important. We didn't speak about a partner with abnormal semen, but if the semen is totally the semen analysis is apparently normal and the male partner is aged, whether this will change the plan or not, that I want to hear, that we didn't answer. So please, I want to hear the answer with that.
So why don't you answer the uterine and then I will get you the answer.
Okay, it's good. It's good. Okay. Yes, I think for me, and for many studies that has been published more recently. Yes, Professor, you have commented about the older studies which originated from the donor, which stated that the pregnancy rate is higher or nearly comparable between the two groups, but nowadays the concept is changed, and the effect of uterine aging, as Professor stated, that many aspects of the uterus, including morphologic, that's endometrial atrophy, and even the myocyte itself can undergo some sort of fibrosis, and this manifested by the higher abnormal labor pattern and the higher rate of cesarean section in older women. The vasculature will undergo some sort of vasculopathy, and what is more important is the abnormal receptor dysregulation in the endometrium. All these factors will culminate together and ending in recurrent implantation failure or recurrent pregnancy loss. So for me, I totally agree with these observations. Okay, and we should respect both the ovarian aging and the uterine aging.
Thank you. Professor Hisham, would you give a comment on Professor Kurt Barner's patient, old age and old male with normal semen? What would you do? Anything different?
I will, of course, first try to change the lifestyle, optimize the lifestyle by, as it was mentioned, decrease the weight, quit smoking, supplementation, and I should be sure that the patient has frozen semen, because it may happen that he might fail to bring the sample at the time of the IVF. But I don't think a lot of changes for me will be done. I will not change the plan.
Very good. Kurt, one last question for you, and then if you can summarize the clinical panel, because afterwards we will leave the stage for the laboratory panel. If you have a last question, or if you do a summary of what we have said, I know that I'm just leaning on you heavily.
My last question, I think, was answered by the panel, so I'll summarize. So again, we're talking about some very difficult patient population here. So what I heard was that women and couples should be very aware of the decline of fertility with age. We all know it, we're talking about it, but I don't think it's reached all people who come to our offices and understand this. I agree that we've decided that advanced reproductive age is really two categories. 35 to 40 is a very treatable category because the quality of oocytes is still relatively good, and the number of oocytes is often good. The category beyond 40 is very difficult because of the very rapid acceleration of the decrease in fertility rate, and therefore it makes expectant management more challenging. And many societies, including ASRM, recommend relatively rapid treatment. When you have rapid treatment, IVF is often a treatment, and I think the panel all agree that that we should be treating in vitro fertilization as women with fragile eggs, minimize manipulation, maximize the quality of your laboratory, and PGTA is really reserved for those that have a large number of embryos to choose from, or perhaps are accumulating embryos. So, and then finally, we heard that we have to take into account other factors, fertility factors we know, such as fibroids, adenomyosis, but importantly, the partner. And the partner's age may affect his sperm quality, which should be assessed very clearly, and healthy lifestyle for both patients in terms of changing lifestyles, removing risk factors, and adding low-cost supplementations are quite a benefit. So with that summation, I learned quite a bit from the panelists, and I'll leave it back to them for the last minute to say, were there any other points that you felt were brought up that I didn't bring up in my summary that you would like to give back to our wonderful audience?
Thank you very, very much. Thank you very much.